our next speaker is Vishal Patel. Vishal's a new associate with Fountain Grove Cardiology. We're very happy to have him. He's an interventional cardiologist who went to medical school at Baylor in Houston, and then did additional training at his internal medicine residency at UC San Francisco, and then back to Texas, to Dallas at UT Southwestern for both his cardiology fellowship and then interventional fellowship. And then he'd been in practice for a couple of years in San Francisco. He's actually joined us with his wife. We have two Patels, Kimberly Brayton Patel and Vishal. So we got a twofer with this one, and we're really happy about it. Kimberly's also a cardiologist. She won't be speaking today, but she will be in the future because we'll tag her. Anyway, Vishal is going to speak to us about venous disease. He has some unique experience and training in this, and we'll let him go ahead. Vishal, please.
Oh, great. Well, thank you, and welcome. I want to thank you so much for giving me the opportunity to come talk to you about venous disease today. Actually, can you guys hear me without this? Okay. So, I was asked to talk about updates in peripheral vascular disease, and while a lot of people might think that automatically means peripheral arterial disease, the venous circulation is a large part of the peripheral vascular system. And I would say it's largely an ignored component of peripheral vascular disease. I can tell you personally from my training, we probably had one lecture or two lectures in all of medical school, residency, fellowship. And that's unfortunate because as I'll show you, it's very common and can be significantly disabling. I have no relevant disclosures to this talk. The goals of today are, hopefully by the end, you'll be able to define lower extremity venous anatomy and function, recognize symptoms and signs of venous disease, and then understand therapeutic options. And I want to be clear, this is not a talk about cosmetic vein disease. Therapy is really aimed at reducing symptom burden. And then any cosmetic benefits really are just off-target effects that happen because of the therapy we administer. So how do you define chronic venous disease? Well, it's a little tough, but it's basically defined as a morphologic or functional abnormality of the venous system. And because it's chronic, it needs to be of long duration. A lot of people use chronic venous disease and chronic venous insufficiency interchangeably, and that's probably acceptable for day-to-day practice. In the literature, if you read about this, chronic venous insufficiency is really reserved for chronic venous disease of increased severity. So that typically means patients with skin changes such as pigmentation, dermatitis, paniculitis, so inflammation of the subdermal fat, or ulcer disease. So the venous anatomy can be divided into two systems. So there's the deep system and the superficial system. The deep system lies within the deep fascia, typically in the muscular compartment, and it's paired with the arteries that we're all probably familiar with. So the external iliac vein, the common femoral vein, the deep and superficial femoral veins, popliteal, and then the lower extremity deep veins. The superficial veins lie within the superficial fascia. The longest vein in the body is the great saphenous vein. It originates at the medial part of the foot, just anterior to the medial malleolus, coming all the way up the medial side of the leg, up the calf. And then here it penetrates into the deep fascia and joins usually with the common femoral vein. The small saphenous vein runs on the lateral side of the foot, coming all the way up posterior to the calf, and typically joins the popliteal vein, sometimes below the knee, sometimes above the knee, and there can be even variations of this anatomy. There's a third system, perforators. So perforators take blood from the superficial system and direct it towards the deep venous system. The venous system function, as you all know, is supposed to bring blood from the feet all the way up, and it's pretty remarkable that this system can do that. because there's no pump in the veins. So it does this all via passive mechanisms. There's two primary passive mechanisms that allow blood to come up the leg against gravity. And one is the calf muscle pump, and the other is the negative intrathoracic pressure of the chest. So as you walk, the calf muscle pumps blood from the deep venous system up, and that creates a reservoir then in the deep venous system such that blood can then flow from the superficial via those perforators I told you about into the deep venous system. All of this kind of complex system is dependent on intact venous valve function. So here's a schematic. On the left, you can see this is a healthy vein. So blood flows up the vein. There's a valve here, which then closes, preventing blood from flowing backwards. Underlying sort of the pathophysiology of venous insufficiency is a damaged vein valve. So what happens is either the valves become scarred from injury or inflammation, or the veins dilate, stretching out so the valves become completely incompetent. Blood then is able to still flow up, but since the valves are no longer touching, it just flows right back down the vein. So the pathophysiology of venous insufficiency typically starts with venous hypertension. That leads to venous dilation and valve distortion, sort of as I've shown you. And it's thought that that valve distortion causes altered blood flow and shear stress, which causes inflammation. This inflammation leads to further valve and vein wall changes, and after enough time, the valves then begin to reflux, so blood starts flowing the wrong direction. That reflux is thought to lead to edema, and then that compounds the inflammation. And over time, with enough inflammation, you develop skin changes and ultimately ulcer disease. So venous disease is incredibly common. Here's a study from the University of California, San Diego, where they took former employees and evaluated them for venous disease. And over 80% had some sign of venous disease. That's 8 or 9 times more common than coronary and peripheral arterial disease. That being said, a lot of these patients had very early stage venous disease, so just spider veins, about half of them. But about 2/3 or a third had more advanced forms of venous disease, such as varicose veins or trophic changes, and by that I mean skin changes. If you look at symptomatic venous disease, it's about 25% of the population. Still 5 times more common than coronary artery disease. Twice as common as coronary artery disease and 5 times more common than peripheral arterial disease. So incredibly, incredibly common disease. In the US, it's estimated that there are about 2.5 million people with chronic venous insufficiency, so the more advanced forms of disease, and about 20% of them have ulcers. And ulcers are really important because they cause significant burden on the health system. So delayed healing and recurrence are very common with venous ulcers. It's estimated that 2 million workdays per year is lost from venous ulcer disease. 12.5% of patients with ulcers will actually retire early because of their ulcer disease. And about $3 billion a year is spent on venous ulcer care. So very, very high burden on our system. And despite being so common, very few patients are actually treated. So it's estimated that there are about 30 million with some form in America with some form of venous disease. Only about 1.9 million seek treatment. And only about a quarter of those are actually treated. And the vast majority really remain undiagnosed and untreated. Who gets venous disease? Well, it affects both sexes very commonly. Over 60% of men, over 90% of women. So women certainly more commonly. Men are thought to have more severe forms of venous disease, though in some studies that doesn't hold true. It's definitely a disease of the elderly. So as you get older, the prevalence becomes more common. Some people will say it's about the same as the decade of life you're in. So if you're in your 50s, it's about 50%, 60, 60%. That's a slight underestimation, but a really good rough estimate. Who else gets venous disease besides the elderly and women? So there's genetic risk factors. Certainly if your mother or father had varicose veins or venous insufficiency, you're much more likely to get it. While I'm a big fan of the standing desk, for those of you who do this, be careful because a lot of standing actually increases your risk of venous disease. So those who stand a lot have to be a little careful. Increasing number of pregnancies is associated with venous disease. So I've had a lot of patients tell me, My venous disease really started after my second or third pregnancy. Smoking certainly is associated with venous disease. It's also overlapped with peripheral arterial disease, so sometimes it can be hard to separate the two. And then obesity is also associated with chronic venous disease. So what symptoms do patients have when they have venous disease? Well, a lot of patients will tell you they have heaviness in their legs. Their legs feel heavy or painful. And that pain can be highly variable. So it can be a generalized ache, so my whole leg aches, or it can be a very localized discomfort. And if you have localized discomfort over a visible vein, that's actually called phlebalgia. A lot of patients will have swelling, cramps, and itching related to the inflammation. In this study, they looked at sort of a questionnaire trying to figure out which questions really correlated with venous disease. And if you have restless or impatient legs, that's about 95% specific for having venous disease. So those patients who have restless legs think about venous disease as an etiology. A lot of these symptoms, can be caused by many things. So one of the things we do is try and separate out venous disease symptoms from other things. So peripheral arterial disease, arthritis can cause a lot of pain in the legs, obviously, and swelling sometimes. Neuropathy is another common one. I get a lot of patients sent to me for swelling, and so one of the first things that I do is make sure they don't have kidney disease, heart failure, liver disease, thyroid disease, and so they get a pretty thorough workup for all these other systemic conditions before we jump to the diagnosis of venous disease. But a couple of things can help you distinguish whether someone's symptoms are due to venous disease from these other causes of pain in the legs. So typically venous disease is worse with standing or sitting for a long time. It improves with elevation. So a lot of patients will tell you, my symptoms are better in the morning, my legs feel great. Patients with really severe venous disease will have symptoms in the morning, but often it's better. It typically increases along the day. So after being on your feet for a long time, patients say my legs feel heavy and more swollen. It's worse in the heat and improved in the cold. And it's usually not worse with walking, unlike peripheral arterial disease. There's something called venous claudication from patients when patients have really severe venous disease. But typically, venous disease gets better with walking. So when you're thinking about venous disease, it's important to do a really good exam. So exposure is really important. You've got to look at the leg all the way from the groin all the way to the foot. And it's really important to look at the belly. Here's a young man who presented for varicose veins, and you can see he's got this varicose vein that goes across the lateral side of his abdomen. This patient actually has iliac vein obstruction, treated completely differently than patients with chronic venous insufficiency. So this guy needs an iliac angiogram and an iliac vein angioplasty and stent. Adequate light is really important. Standing position is also very, very important. So I have all my patients stand up when I take a look at their legs because their varicose veins will actually completely subside when they're in the supine position. And when you stand them up, you'll be surprised how many more varicosities you'll see. I usually divide the leg in my mind into three categories. So the ankle, the calf, and the thigh. And basically, the more severe your disease is, typically the higher up it is. So patients who have thigh varices are usually worse off than patients who just have stuff at the ankles. Whenever we see these people, we try and put them in a category of disease. So there's something called the SEAT classification for chronic venous disease. This stands for clinical, etiologic, anatomic, and pathologic. The clinical part is probably the most important of all of these things, so we always try and put people in one of these things. So C1 is telangiectasias or reticular veins. They're spiders. Reticular veins are a little bigger than spiders, but not big enough to be called a varicose vein. That's usually very early stage disease. A lot of those patients are not symptomatic. They don't need any therapy except sort of preventive things. Varicose veins, that's a little more advanced form of disease, and a lot of these patients will have symptoms. They'll have pain over their varicose veins or a lot of heaviness, aching, discomfort in their legs. C3 disease is edema, so swelling in the legs. And then C4 through 6 are much more advanced forms of disease. So once you start having pigmentation or venous dermatitis, that's considered C4A. C4B is when you have lipodermatosclerosis or atrophy blanche. So lipodermatosclerosis is inflammation of the subdermal fat and fibrosis. And what happens is that the underlying skin will actually then adhere to the subdermal tissue. And many of these patients will have what's called an inverted champagne bottle or bowling pin appearance to their leg. So very skinny at the ankle and very fat at the calf. Atrophy blanche is when you get white sort of scarring due to necrosis of the skin without full ulcer formation. And then C5 is when you have a healed venous ulcer. C6 is obviously the most advanced disease when you have an active venous ulcer. Typically, these are on the medial side of the leg. There are a couple mimickers to be aware of. So lymphedema is one of the causes of swelling that you need to be aware of. So this patient has lymphedema. How can you tell whether patients have lymphedema or not? Sometimes it's not easy, but there's one sign you can look for. It's called the Kaposi-Stemmer sign. So the idea behind this sign is that you try to pinch the tissue, the skin tissue at the base of the second toe. If the skin tense, that's suggestive that it's not lymphedema. Lymphedema, fluid is usually very protein rich and causes a lot of thickening of the skin. And so the skin becomes not easily tentable and very difficult to pinch at the base of the second toe. If that's positive, meaning you cannot pinch it, that means the patient does have lymphedema. If it's negative, they probably don't, but it doesn't completely exclude lymphedema. Another thing that suggests lymphedema is papillomatosis. So these little papillomas also are highly suggestive of lymphedema. But just because a patient has lymphedema doesn't mean they don't have venous insufficiency. In fact, the most common cause of lymphedema is probably venous insufficiency. So if you see other signs like this patient who has hyperpigmentation, you got to think about venous insufficiency as the underlying cause. That's known as phlebolymphedema. Lipedema is another common mimicker. So this is a classic patient with lipedema. So you can see there's edematous legs, but characteristically lipedema stops right at the ankles. So the dorsum of the foot is usually spared. So if you see this where it looks like they have edema, and then boom, it stops and the dorsum is spared, that's usually lipedema. And typically it's symmetric. Okay, so when patients come to us, we do a couple things. So a very detailed symptom history, trying to figure out their exacerbating and alleviating factors, and we're really trying to pin down whether their leg symptoms are due to venous disease or not. A really thorough venous examination, trying to look for signs of venous disease. But know that 20% of your patients who have symptoms due to venous disease will actually have a completely normal exam. And when we ultrasound them, we find subdermal varicosities that just aren't visible to the eye. We also do a very specialized severity score, trying to figure out how severe their venous symptoms are. So this is called the VCSS, or Venous Clinical Severity Score. It's got, I think, 10 attributes on a scale of 0 to 3, where 3 is more severe and 0 is not severe disease. And we come up with a summary score for how bad their symptoms are. So this is just a sample from our chart of an imaginary patient, actually. And each time we see them, we do this score. And we can actually track whether their symptoms are improving over time. So when you treat patients with vein disease and you're trying to get their legs feeling better, this score should be going down. So I think it's really important that this is done in patients who are really done for your patients, because if this score is not getting better, you're probably not treating the right underlying disease. Okay, so, and then the last thing is venous duplex. That's really a cornerstone of diagnosis now. And what we're looking for is that pathologic reflux that I showed you in the diagram. We're looking to see if blood is actually flowing the wrong direction. So here's a Doppler tracing of the left perineal vein, a pulsed wave Doppler tracing. And you can see here's blood. They do an augmentation maneuver. You can see blood flows up the vein, and then it actually starts flowing backwards. All of this is blood flowing backwards down the vein, and we can actually measure this reflux time, and when it's greater than half a second, that's considered pathologic reflux. So what can we do to treat these patients? So conservative therapies are important for everyone, and I offer it to everybody. Exercise, leg elevation, compression stockings, or Una boots. And then there are a few invasive therapies we're going to talk about. Conservative therapy is really, really important. So exercise is very important for these patients. Here's, unfortunately, this diagram. something happened in the transfer of the diagram. So basically, this is a study from 1948 where they looked at ambulatory venous pressure. So when patients are standing, what this should show is that the ambulatory venous pressure is about 90 millimeters of mercury. And as soon as the patient starts walking, which are these humps right here, the pressure drops significantly. And post-exercise ambulatory venous pressure is about 30 millimeters of mercury. So significantly lowered when you exercise. Similarly, when patients elevate their legs, venous pressure drops to about 0. So I always tell my patients, whenever they're sitting, prop your legs up. It'll lower your venous pressure significantly. Okay, compression stockings. I get a lot of questions about compression stockings. Which kind, how high, what strength. And probably it doesn't matter. The most important thing is that they wear them. So knee high or thigh high, if you have patients who have symptoms all the way up to their thigh, they probably should wear thigh high. If everything's below the knee, then knee high is adequate. Compression strength, so there are basically 3 strengths. Each company kind of has different ratings, but they're usually a low, medium, and a high grade sort of compression. Low grade is really only for patients with mild symptoms of spiders, mild or asymptomatic. Medium is for patients who have more severe symptoms, slightly bigger varicosities. If you have severe symptoms, severe varicosities, lots of swelling or ulcers, you really need to wear high grade compression stockings. But most importantly, choose something that your patient's actually going to wear. So don't give the 90-year-old woman with terrible arthritis knee-high 30 to 40 millimeter compression stockings. She will never get them on, and she'll never wear them. I think it's better that you give that patient something that they're going to wear to at least help them. Okay, so all those conservative therapies really are aimed at reducing venous pressure. Invasive therapies are designed to remove the source of reflux. So vein stripping had long been sort of the mainstay of therapy. And typically vein stripping, what happens is the surgeon makes this incision in the groin, ligates the saphenous vein at the saphenofemoral junction. That's called a high ligation. And they put this vein stripper through the vein. They then avulse the vein, pulling it out and getting rid of that portion of the saphenous vein. Usually it's combined with a couple of other incisions here to remove any tributary veins. This procedure obviously is very morbid and painful, and it's kind of been replaced by other therapies. And a lot of that's because there's a significant risk of complication from stripping. So hematoma can happen, infection, saphenous nerve injury occurs in about 10% of vein stripping cases. DVT is common, 5.2%, PE 1.5%. You can reduce this risk with prophylactic DVT therapy, but then your risk of hematoma goes up significantly. Superficial thrombophlebitis is common. Many patients have significant postoperative pain, and there's about a 20 to 28% risk of varicose vein recurrence. So stripping has largely been replaced by endovenous therapies, and the one that I typically use is radiofrequency endovenous ablation. So the idea behind this is that a catheter can be inserted under ultrasound guidance into the saphenous vein. The vein can then be anesthetized with a tumescent solution consisting of saline, lidocaine, and some bicarbonate, and that really separates the vein from the surrounding tissue, separates the nerve from the vein, and then radiofrequency thermal energy is then applied, causing a fibrotic reaction in the vein, and that vein will actually shrink over time. It's quite effective. It's an outpatient procedure. There's essentially no recovery time. In fact, we tell our patients after this procedure is done, you should walk every day for about 20 to 30 minutes a day. It's actually good for your legs and will increase the efficacy of the procedure. It takes about an hour, though some patients can be done even faster. Sometimes it can take a little longer. And it's covered by most insurances for symptomatic venous disease with documented reflux. How good is endovenous ablation? So at 1 year, about 97% of the veins are closed. At 5 years, 90%. So about a 10% recurrence rate over 5 years. Some patients will need additional ablations or injections, but quite good at keeping the vein closed. Complications are very, very uncommon. So the most common complication is just ecchymosis, so bruising along the length of the treated vein, 6%. That's gone at 3 months. Erythema, hematoma, very rare, around 1%. No infections. Pain, about 1.8%, and it's usually pretty mild pain. Most patients are able to walk and still function normally. Paresthesias can happen in about 1.5% to 2%. Typically, this can be reduced, I think, even further with really good tumescent technique where you keep the nerve off of the vein. And how good is it? So this is that venous clinical severity score that I showed you earlier, and basically looking at 682 consecutive limbs treated with endovenous ablation. So pain, you can see this. Remember, the score is from 0 to 3. Goes down significantly from baseline to 4 months after endovenous ablation. Varicose veins also shrink, edema gets better, inflammation gets better. Ulcers, very few patients had ulcers, but those also get better and can be healed with this therapy. Comparing it to surgery, here's a meta-analysis of 8 randomized trials. It's essentially equivalent to high ligation and stripping in terms of recurrence. So it's largely replaced surgery, and very few patients get surgery anymore for venous insufficiency. A couple of quick cases I just wanted to show you. So here's a 42-year-old man who has severe right leg pain and swelling. You can see he's got this large varicose vein that starts at the knee and comes down. He has severe reflux of his greater saphenous vein here. He underwent an ablation. You can see this is the tiny little catheter site where the catheter went in, and already his varicose veins are shrunk. He has no pain, no swelling. He's back to his normal level of function, and he feels great. Here's a more severe case, 75-year-old, severe pain, redness, heavy, achy legs. Gets an ablation 4 months later. This is what their leg looks like. They're feeling much, much better. 68-year-old with a non-healing ulcer here. Also had a severe insufficiency of the greater saphenous vein, lots of tributaries. Gets an ablation and injection of some of those tributaries. Sorry, that is not the picture. Look, it's so much better now. Yeah, so I don't know what happened, but imagine that this was healed. So in conclusion, chronic venous disease is the most common vascular disorder. Symptoms can be significantly disabling. Only a small proportion of patients are actually treated. And endovenous ablation offers equivalent results compared to surgery with lower complication rates. And with that, I'll take any questions you guys have.
Question over
Where was I? Saw it. Okay, sorry. Okay, I'll start here and we'll go this way.
Is Partnership Health Plan currently paying for the endovenous therapies?
That's a really good question. We actually have a meeting next week to figure out what to do, because we don't know the answer. It's covered by Medi-Cal, so I don't know if that's kind of similar to Medi-Cal. For Medi-Cal, you need a TAR to get this covered, and so we're going to have to figure that out, but we'll have an answer for you shortly.
I'm missing something about the anatomy.
Sure.
So you have a diseased vein. Presumably, most of the veins in the leg are diseased, and if you remove one or occlude one, how does the blood get back up again more efficiently?
Yeah, really, really good question. So, on average, patients will have about 2 veins which are refluxing, and there's a lot of redundancy in the system. The deep veins typically don't reflux. Because they're within the muscular compartment, they're not as subject to the high pressure. So the deep veins usually remain competent in these patients. So what happens after you get rid of the refluxing vein is, because there's so much redundancy, the other veins actually pick up all of the work. And venous you can show that venous pressure actually drops as soon as you take out the refluxing vein. And that's just because other competent veins are there.
I see a lot of 80 and 90-year-olds, and they have gait disturbances where they don't have effective muscle contraction, and maybe a little pump failure, heart failure with preserved ejection fraction. And I'm always a little worried. We throw a lot of Lasix at these folks, and they get dehydrated and wilt so easily, and I virtually never thought about what you're performing for these folks. But can you talk a little bit about the clinical management maybe of that? That's kind of what I see a lot of, and then they do break down sometimes.
Yeah, that's actually very common that a common scenario. So patients with edema that get started on Lasix, and then the next thing you know, they're hypotensive, dizzy, and their creatinine's starting to bump. And I think that's certainly a scenario in which you got to think about vein disease. It's not a one-to-one correlation, that's definitely, but it definitely, it makes me wonder a lot about those patients. And so I think a reflux study in those patients is really easy. It's non-invasive. It takes about 45 minutes to an hour, and you'll have an answer of whether the veins could be contributing or not. A lot of times in those patients, when there's ambiguity about what's happening, we'll treat one leg first and see if their symptoms get better. And if their symptoms get better, then that sort of argues that it's probably venous disease, and then we'll treat the other leg too. But you know, that's one of the challenging things we deal with is swelling when there's other things that could be causing it. It's hard to know sometimes.
During the 23 seconds I have to actually listen to my patients, I happen to find out that I have a large group of patients that never get into bed. They exist in a recliner or sometimes even in a chair leaning over a table, and their legs are inevitably edematous and go through all these changes. I'm just wondering, is it just my practice, or do you see that too?
Yeah. No, it's incredibly common that the disease is incredibly common. I don't, you know, sitting in a recliner is a little bit unique, I think. But yeah, even just if they're gonna sit, if they just put their legs up a little bit, it's helpful. They don't have to do the whole above your heart thing. Just put them up a little bit, and that certainly lowers venous pressure.
Is it contraindicated to use high pressure compression stocking in patients who have both venous insufficiency as well as peripheral arterial disease?
Yeah, also very good question. So if you have just run-of-the-mill peripheral arterial disease where you have claudication, you can probably use high compression stockings. But if you have arterial, critical limb ischemia, so you have an arterial ulcer or rest pain, then it would probably be relatively contraindicated to use high-grade compression stockings. So I wouldn't recommend you use it in patients who have rest pain from their peripheral arterial disease or from ulcer disease. Usually those patients that are getting some other, revascularization, and once that's complete, I think then they can have compression therapy.
Was regarding the question by the colleague there, the female colleague, was the patient who had all venous problem, deep and superficial. Is it true that the answer remains applicable also to the procedure we are recommending now, other than stripping, that in case of deep venous insufficiency, you are not going to do the procedure? That's what she was asking, I think.
Yes, so if you have deep and superficial insufficiency, those patients are very, very hard to manage, actually. Sometimes ablating their superficial vein can worsen their symptoms. Sometimes it can help. It's very hard to predict. We're very careful with those patients. So if you have both deep and superficial insufficiency, I'm hesitant to just go outright to an ablation. I would probably really try really aggressive conservative therapy, and if they fail that, and particularly if they have ulcer disease, those are the patients that I would be a little more willing to try an ablation to see if it helps their symptoms. But yes, so if that was your question, if the deep system is abnormal, then yeah, that's tougher. There's not really good therapy for deep venous insufficiency. Some people have tried taking segments of the axillary vein and transplanting them into the deep system because that'll give you a competent vein valve again. Doesn't really work that well, but it's potentially an option. But the good news is deep insufficiency is not so common. So about 80% of the patients who have venous insufficiency actually have superficial reflux. So deep is there, but it's not nearly as common as superficial disease.
Dr. Dawson. How do you juggle the consideration of an ablation procedure, for people that say have coronary disease and they also have varicosities? I mean, maybe they don't have ulcerations, they have significant varicosities, and you can always use that. At what point can you not use that saphenous vein for a arterial conduit?
Yeah.
When do you save it and when do you get rid of it?
Yeah, good question. So and this is probably a moving target, but some people are very extreme and say that, if your vein's refluxing, that's really not a good vein to use for saphenous conduit for bypass anyway. So some people use that argument. I don't think we routinely look for reflux, so probably some patients are getting refluxing saphenous vein conduit. And it's hard to know. Certainly, some of those people will use they won't have viable veins anymore for bypass. So it's hard to predict who's going to need a bypass. Less and less people are getting it these days, and where stent technology has evolved so much that a lot of people can be stented now. But it is one of the downfalls potentially if you use up all of their saphenous conduit.
Is this less effective in people who had recurrent DVT?
So patients with recurrent DVT are interesting. A lot of them will have deep venous reflux because of deep damage to the deep valves. So it may not be effective in those patients. If those patients have a lot of superficial venous reflux, it can still be effective. If they still have a DVT present, this is really contraindicated because you need some outlet for blood to come up the foot. So if your deep system is obstructed, we really can't ablate your superficial vein, otherwise the leg will get worse. So we make sure all patients who get a reflux study actually get a DVT study as part of it to make sure there's no DVT at that time.
Okay, great. Thank you.
Thanks.